everyone. Thank you for your attention so far, and thank you to the Canadian Digestive Health Foundation for this wonderful opportunity. The program so far has been fantastic. So at this point, hopefully you're all believers that the microbiome has a big role in pretty much everything. This next talk, though, is going to be about something that is generally not conversation topics around dinner tables, but hopefully by the end of this, if I can achieve that, I'll at least have you excited that this does have tremendous opportunity for the future of gastroenterology. So by way of quick disclosures, I'm a member of the NASPGHAN Fecal Transplant Steering Committee, which is tasked to try and bring fecal transplant to clinical practice in hospitals around North America. I sit on advisory boards for AbbVie and Janssen. I'm the principal investigator of a fecal transplant trial that's currently happening in Pediatrics, and I also receive research materials in kind from Rebiotics. So these are our learning objectives for today. So we're going to start off by talking about how exactly is fecal transplant done. I will try and save you too many of the gory details, but I think that is a starting point for the rest of the discussion. What are the proposed clinical indications to do this? And then finally, we'll talk about some numbers. So does this actually work, and what data do we have? So to begin with, we call this FMT, so Fecal Microbial Transplant. But there's a lot of terminology that's out there that sort of describes the same thing. So sometimes you'll hear the terms bacterial transfer. There's also the term stool donation, which sounds very beneficent, like you're going to the food bank. At the end of the day, though, all of these different terms, these euphemisms, are all explaining pretty much the same thing. So you start off with this healthy poop, or a poop emoji. It is transferred to an average Joe who has some ailment of some kind. And at the end of it, average Joe, post-fecal transplant, becomes better, becomes healthier for it. So right now, there are several official, but also slightly more concerningly unofficial techniques that are out there of how to do fecal transplant. And I'm certainly not endorsing this website, but just so you know that it's out there, there's a website that is called thepowerofpoop.com. And if you log in and access that site or the YouTube videos, you'll see hundreds of thousands of hits. And what they propose to do is to bring fecal transplant to one's home. And there are some very vivid step-by-step details of exactly how to do this. There is a before picture here. I've saved you the pleasure of seeing the after shot, but that blender is not quite the same. Officially, there are several research protocols that have been described in the literature, and these are investigators that have performed the few fecal transplant RCTs that have published their methodologies. Now, in terms of the regulatory aspects, so the FDA, the Food and Drug Administration, and Health Canada have published what are called guidance documents. So these are more broad strokes guidance, recommendations on what a physician or a clinician should be doing if they're offering this to their patients. But as I'll get into in a couple of moments, the guidance is somewhat vague in areas. So, for those of you who are interested, these are two methods that have been described. And you'll see in these, let me find my pointer. You'll see in these red and blue boxes, there are some subtleties that differ between the different methodologies. How much stool to use, etc. Where things get really interesting, though, is what you do with that prepared stool. So do you administer it via an enema? Do you give it to someone through a colonoscopy or an upper endoscopy? Or do you insert a nasogastric tube or an NJ tube and give it to them through that? Point is, there's many different methods that exist. And this is one of the challenges, that there isn't a set methodology that we currently have. Now again, so we talked earlier about how Health Canada has guidelines, and some of these guidelines, these suggestions, talk about the need for a single donor, having that donor known to the physician or the patient, screening of various different kinds, and also record keeping of that donor in case you want to do some trace back later. Some of the things that the guidance documents don't speak to, though, which is largely the subject of current research now, is do you use a household or an anonymous donor? There is a lot of literature out there right now that describes how individuals who share the same household, so essentially the same immediate local environment, often have pretty similar microbial patterns. So if the whole goal of this is, in some indications, to try and replace a presumably unhealthy microbiome with one that is very different, even though it's obviously easier to ask one's family member than find a neighbor down the street to give you a fecal transplant, is that really the best thing we should be doing? Fresh versus frozen samples, we're going to talk about some literature there. And then also, what's the best way of delivering this? An enema versus a scope. All of these things, though, for those of us who are trying to provide this for our patients, presents challenges. So we need a proper setup, cleaning of biohazards, precautions around handling, donor screening. So we talk about things like lifestyle screening, but what exactly is constituting an unhealthy lifestyle when you choose a donor? As one example, there was a case report just in 2015 of a child who was the donor for her mom who had recurrent C. difficile infection. The child had obesity, the mother did not, but after that fecal transplant, within 1 year, the mother gained 8 BMI kilogram per meter squared points within 12 months. So presumably the question was obesity transferred via this fecal transplant? So maybe we should be screening in lifestyle questionnaires for aspects of metabolic syndrome. The final comment here, though, is, and this is something to be mindful of as I go through the next slides, is that natural is not always safe. So we are conducting a trial right now, and there's a tremendous amount of excitement for this therapy. But just as we saw with things like Canadian Blood Services in the 1980s, other very natural things like blood products oftentimes can contain a lot of very unhealthy things for us. So the challenges of not having a clear protocol definitely come up in practice. All right, so is FMT something new? So for those of us who have been sort of following this literature, it seems like over the past couple of years there's been a tremendous amount of excitement for this. But the truth is that stool has actually been used as therapy for centuries. Going back to 4th century Chinese medicine texts, we see that there's descriptions of stool being used for the treatment of gastroenteritis and diarrhea. In World War I and II, soldiers would often use camel feces to treat bacterial dysentery. Where this got into clinical practice, though, was in 1958, when it was first used to treat recurrent C. diff infection. We probably all know this in this room, but C. difficile is an intestinal infection caused by this bacteria, Clostridium difficile, and it has tremendous morbidity and mortality, particularly in the older age groups. There is antibiotics that can be used to treat this, but the problem is that C. diff often comes back, and as a result, based on a number of studies, which I will get into shortly, fecal transplant has now been largely recognized as a bona fide last resort treatment for adults who have recurrent C. difficile. How about other indications? So I'm a pediatric doctor, so how about in our kids? So data for FMT in recurrent C. diff in kids is limited. There's been only a few case series, and part of the reason is because C. diff doesn't really happen quite as frequently in our age group. The studies that have been done, though, were able to show us something that was very interesting. So some of the kids that do get C. difficile have another major risk factor. They also have inflammatory bowel disease, so Crohn's disease or ulcerative colitis. And what was seen in several of these small case series is that in those kids that got fecal transplant for their C. difficile infection, who also had Crohn's or ulcerative colitis, not only did their C. diff get better, but in a few of these patients, their Crohn's or ulcerative colitis got better too. Now, some other interesting data that's come out was back in 2014, a large multi-center study was done looking at the bacteria of pediatric patients who had inflammatory bowel disease. And it was shown that there are some very unique classical bacterial signatures in pediatric patients with active as well as inactive Crohn's disease. The same thing has been shown for ulcerative colitis. So given that, as we heard from our last speaker, there could be some pathognomonic microbial signatures that characterize Crohn's and ulcerative colitis, it's even further reason why the possibility of using fecal transplant for treating IBD has really come to the fore. So currently at McMaster, we're conducting the first randomized controlled trial of fecal transplant for children. This has a slightly different regulatory process because it is purely based on research, and we're providing placebo-controlled serial fecal enemas for ulcerative colitis. We're currently expanding to London and Montreal Children's, but I'd be happy to speak to anyone about this after the talk today. With all the things that we have heard so far, hopefully we all can appreciate that the brain-gut immune axis is something that is very interesting. And certainly when we look at animal studies, there is data suggesting that the microbiome has a big role to play in things like obesity, metabolic syndrome, NAFLD, anxiety, and depression. All of these things inevitably lead to questions for human studies. And especially when we look at things like the powerofpoop.com, unfortunately, as scary as it is for many of us, our patients are looking at the same data and then looking at online resources as a way to maybe give themselves a fecal transplant. So I think one of the things that we can all appreciate is clinical trials offer regulated options for patients and sometimes may also give us some of those early aha moments that lead to new treatments. And certainly with fecal transplant trials right now for inflammatory bowel disease, that's one of the hopes. All right, so let's finish up with some numbers. So does it work? We know that the greatest evidence right now for fecal transplant comes from the recurrent C. difficile literature. And there's been 3 randomized trials, 29 case series, that has illustrated this pretty reproducibly. In terms of the numbers, so antibiotic therapy for recurrent C. diff, about an 85% long-term response, only 50% in seniors, which is very poor. FMT for recurrent C. diff, 90% long-term response rate with just 1 treatment. Also, in a study that is cited at the bottom of this slide, no recurrence for 2 years and no significant adverse events. Now, one of the adverse events that has been reported in patients, particularly with inflammatory bowel disease, is the onset of a fever that lasts anywhere from 4 to 12 hours. But generally, these patients can be treated with a single dose of antipyretic like Tylenol, and no further complications have consistently been reported. At this point, it's really not a question of whether FMT helps C. diff, more than asking ourselves what's the best way to give FMT for these patients. Fresh versus frozen stool has been shown to be equally effective, and that's a really huge deal for clinicians. As you can imagine, if a patient rolls in and you don't yet have a setup to prepare a fecal transplant, if you have to obtain a fresh sample, that's challenging. The fact that frozen samples can be equally effective has really opened the doors for many smaller centers to be able to access this treatment when needed. A study came out of Guelph, as well as from the University of Western Ontario too, that looked at a stool substitute therapy called Repopulate. So 33 bacteria were isolated from 1 healthy donor, and the results that have been published so far have been small, but 2 patients were reported to have done very well and were cured of their recurrent C. difficile. I understand one of my colleagues earlier gave a talk about her findings in her center looking at the role of colonoscopy FMT versus a similar stool substitute therapy as a pill, and those results are going to be published shortly, but also are supporting this other option. How about FMT for Crohn's and colitis? So data that you have heard already as well. It's less well studied. There have been 2 very well-designed adult trials. So in 2015, Paul Moyetti and colleagues from McMaster, from our center, performed a randomized controlled trial looking at the role of enemas from anonymous healthy donors versus placebo. And there were significant findings. The recipients with ulcerative colitis who received the fecal enemas had a 23.7% response versus 5.4%. That was significant. Interestingly, though, that very same year, another group from the Netherlands also published a study with slightly different methodologies that did not show a significant response. So the data is mixed, but it does suggest that there might be a signal. And then finally, in pediatric studies, once again, smaller numbers. There have been 4 small case series that have been published, 25 patients total, all using different protocols in their treatment of pediatric ulcerative colitis and Crohn's disease. But in total, 56% of those patients showed a clinical or endoscopic response. So once again, there is a signal here, but we need well-designed studies. So what's happening? Why does FMT seem to work? Unfortunately, as you've heard multiple times today from other speakers, the somewhat unsatisfying answer is that it's still sort of unclear. One of the things that we've seen is that in patients who were treated for their recurrent C. difficile after receiving a fecal transplant, at first, the patient's microbiome, the recipient, resembled the donor's microbiome. That was consistent with them feeling remarkably better. But those changes are short-lived, and within about 3 months or so, the recipient eventually returns their microbiome back to their baseline, but the C. difficile doesn't come back. In patients with Crohn's and ulcerative colitis who have shown a response to fecal transplant, there's really no sustained difference in the microbiome between the patients who respond or don't respond to fecal transplant. So once again, interesting clinical findings, but when we go back to looking at the underlying bacteria, it's hard to really find a pattern to know what's happening. Now, are there some other explanations for why we can't find a signal? Well, maybe because we're not really measuring the right things. So classically, we measure structure. So looking at this picture here, we count the number of bacteria that have this shape, and this one. But perhaps instead of looking at structure or quantity or relative abundance, we need to be looking at something else like function. So potentially those bacteria that are fewer in number and maybe also harder to capture and analyze actually have a disproportionate function in the person's microbiome. So that's one of the questions. In the Paul Moietti study, as has been alluded to earlier, there was one donor who had a huge impact on being able to provide benefit for patients who had given their stool sample. And that microbiome in that donor looked very similar to all the others, but much like we understand now with organ transplant, where you need to have a good match between the donor and the recipient, maybe there is something to that as well to make a fecal transplant really stick for some patients. Unfortunately, though, we don't really know what those variables are, but it was shown in the Moietti study. And then finally, maybe there's something to be said about delivering the right bacteria to the right place. One of the pediatric case series used nasogastric tube infusion for patients with ulcerative colitis, and 0 out of 4 of those patients had any response. Maybe it's because we're not delivering the bacteria where it needs to go. So there are questions that exist. Some final thoughts. So fecal transplant is kind of messy science. It's sort of like the shotgun approach. You just give a whole bunch of stuff and then you hope that the patient gets better. The thing is, with this sort of an approach, it does tell us whether there's a signal. Traditionally, in terms of things like inflammatory bowel disease, for instance, as well as C. difficile, we acknowledge that the immune system has gone haywire because of something that is happening at the intestinal epithelium. And all of our treatments aim to keep that immune system from doing the things that it does when it's affected. Potentially a new approach is to look more upstream and to ask ourselves, what are the reasons that the intestinal epithelium is responding in this way? What are the reasons the immune system is getting overactivated? And using that as our target instead. So how can we finesse this messy science? Well, maybe we can add or remove specific bacteria. As one of the speakers earlier, though, Tom Walters alluded to, it's hard to change just one part of an ecosystem because sometimes other things happen in the process. So that's one of the challenges for the future of this science, but it certainly will take the shotgun approach of FMT and make it a little bit more finessed. So let's go back to our objectives. How do we do FMT? No clear protocols exist, but there are guidance documents that are out there. What is FMT used for? So the best studies right now are looking at the role of FMT for the treatment of recurrent C. difficile. There's also some data and more coming on the role of FMT for IBD. And then finally, does FMT work? We know that FMT is more effective than antibiotics for the treatment of recurrent C. difficile, Fresh versus frozen enemas are equally effective, so huge clinical implications. More trials needed on the role of this in Crohn's and colitis. And the first trial of pediatric FMT in a randomized control fashion is happening at McMaster right now, with expansion to London and Montreal shortly. I'll leave you with this and a question down at the bottom, and happy to take questions. Thanks.
Yes, please.
Hi, for someone with celiac disease suffering from mononucleosis, an adult, and she's had mono for over a year because her immune system is down, would you suggest fecal transplant as a treatment?
Sure, so I'll just paraphrase to make sure I got that. So this is a patient who had C. diff, who also had...
Oh, no, celiac disease.
Sorry, celiac disease,
Yeah.
who also had mononucleosis.
Mononucleosis. Might be a question for Elena, the previous speaker, as well.
I think, so, okay, maybe there's a few ways to answer this. I think right now, the role of fecal transplant is something that is in the research sphere. And when we look at things like C. difficile, and also I would say with IBD, these are disease processes that have either very poor treatments, so antibiotics are just not effective for some of these patients, or the long-term implications are deemed to be too significant and severe, so long-term immunosuppression for a child with Crohn's disease. Some would argue that with celiac disease, as long as we can avoid gluten in our diet, that is a very, very effective treatment for the underlying pathophysiology of celiac. And so to use an investigational therapy that might have more risks than benefits for some, it's a bit of a hard sell. But is there a potential signal, research-wise? Maybe, but I don't know of one, and there's been no studies yet.
Thank you.
Any other questions?
I have a quick one. What's the selection criteria for patients with IBD who may be a good candidate for the fecal transplant?
Yeah, so great question. We are taking patients in our trial who are between the ages of 5 and 17 because they're pediatrics. I'll just point out quickly that the reason for the 5-year-old cutoff is because in children under that, there's an entity called early onset IBD, which might have some more systemic immune pathology there. They're patients who can stay on the exact same medications that they're on, but they show some signs of activity. So whatever they're taking just isn't cutting it. We can talk more later too. Thanks.
I'd like to emphasize what Dr. Pai said really about indications here. In the alternative medicine sector, there are at least 2 books published in Canada about how you can do this on the kitchen table in your parlor. This is something that any serious and properly qualified healthcare professional should discourage at all costs. And I think we've been extraordinarily fortunate in how well patients with chronic refractory C. diff infection have actually responded to this treatment, such that it is a definitive indication, particularly for those who failed antibiotic therapy. But for all of these other conditions that Dr. Pai has mentioned, these are research protocols, and they should be research protocols only. But there are a lot of people out there, and family members, very enthusiastic often on the basis of what's in the public domain, to be encouraging their relative with difficult IBD to go seek this. And I don't think it's as easy. The super donor that you refer to in Paul's study was kind of critical to the interpretation of that trial. And if there hadn't been a very careful look at the phenotyping of the stool donors that were giving, as well as the recipients, we wouldn't have known that one donor had been responsible for most of the successes in the study. And this is highlights the real complexity of something which is apparently so simple. Do you want to comment?
Sure. Thank you for bringing that up. That super donor, that was fascinating. Why was one person's stool able to treat 5 of the 9 respondents? What's interesting, though, and this hasn't been published yet, kind of like we were saying, when we looked at what was in that one person's stool compared to the other, I believe, 3 donors, There was no significant or obvious change. So, just another quick plug, I'm sorry, I'm short on time, but when we talk about this term, a healthy bacteria or an unhealthy bacteria, studies like this just go to show us that we don't know how to define what's healthy and not. That person clearly had a healthy bacteria. They cured 5 patients out of the 9, but there's no signal in terms of certain bacteria that exists or doesn't exist that tells us why. Thank you.
Thanks very much.